NovaMatrix is the next generation soft tissue augmentation material intended for root coverage, gingival augmentation, and alveolar ridge reconstruction applications. The NovaMatrix reconstructive tissue matrix is surgically attached to the desired anatomical location to create a proper interface and regenerate soft tissue. The three-dimensional architecture of NovaMatrix allows blood vessels to grow into the surgical site. NovaMatrix provides a conduit for host cells to penetrate, adhere, proliferate, and populate the reconstructive tissue matrix. The cells contribute to the remodeling by creating a new host tissue. NovaMatrix provides the proper environment that balances mechanical properties of the reconstructive tissue matrix with the host cellular mechanisms of wound healing. This leads to the remodeling of tissue and ultimately the regeneration of soft tissue. The transition of NovaMatrix reconstructive tissue matrix into host tissue restores the physiological and anatomical properties of the surgical site.
Good morning, my friends. Welcome to the Regenerative Symposium days, and on behalf of Sepa and the Oral Reconstruction Foundation, I welcome you all, and buenos días desde Madrid. Good morning from Madrid. Apologies for this 5 minutes delay due to some technical issues with the translation, but it is underway to have full translation into the different languages. I would like to convey to you our preoccupation for the general situation in Europe. As you understand, the trends in terms of viral infection we are suffering are increasing. So more and more we need to be responsible and we need to comply with the recommendations from the authorities. But on the other hand, we're responsible of educating and teaching and providing as much as possible information to our profession cannot stop. We need to continue our goal and our work, and we thank both Sepa and the Oral Reconstruction Foundation for the opportunity to be here and to organize this symposium that I am sure you will enjoy, because we have a superb panel of speakers. So let me take off my mask, but you keep it on unless you are at home isolated like I am right now here. So let me start by giving you some information on the Oral Reconstruction Foundation and also on the program we have today. So if I may have the presentation, please. So the Oral Reconstruction Foundation is a corporate foundation that is aimed to expand the science, the patient care, and the education among professionals interested in implant dentistry and the associated areas around implant dentistry. So basically, as you can see, our mission is to promote young scientists and practitioners, to exchange science and education, and to provide training in specific interventions related to implant dentistry. As you can see in the image, this is the board that is working hard to comply with our mission. And of course, it is the board who was responsible of the program we are having today. As you can see, we are trying to support the research, and you can overlook the tendency of granted projects by the foundation in the last 10 or more than 10 years. And these projects have encompassed different lines from basic science studies to clinical studies to scholarships to young researchers in different laboratories and institutions. And also we have tried to organize expert meetings where we can put the background information into consensus report, into different documents that have been published in high impact journals in our field of work. I think these are important documents that provide evidence of interventions that we practice on an everyday basis. So basically, the Oral Reconstruction Foundation has been stalled due to the COVID crisis, like all the organizations in the world. We had to cancel our Global Symposium, but we are trying to provide online education, and we are trying to gather with important scientific societies, like in this occasion we are doing with Sepa. So let me go directly to the symposium we are starting today, Novel Regenerative Concepts for Soft Tissue Augmentation and Improved Healing. So basically we are going to discuss the advent of soft tissue augmentation materials. We will review the biology, we will review the rationale of using these materials, and what is the clinical outcome of some of the experiences working with this technology. Later, we will have a panel discussion with three very important experts in this area of dentistry, and I'm sure we will have a lively debate on putting together some of the concepts that have been presented by our speakers. So basically, we are going to discuss two main clinical problems. One problem is localized gingival recessions around teeth. And of course, we understand that this clinical problem is unrelated from periodontitis. It's a clinical problem related mostly with traumatic lesions associated with specific thin morphotype, specific interventions and specific situations that happen in the day-by-day activity, and basically they cause important aesthetic problems that the patients want to solve. We now have a new classification of these mucogingival conditions that has been recently approved, and now we are trying to achieve with our interventions the best possible outcomes for the treatment of these conditions, which is basically to reconstruct the soft tissue lost, and of course to reconstruct it, but with an outcome of excellent aesthetics, excellent blending with the adjacent tissues, and of course the complete coverage of those exposed roots. The current therapeutic approaches basically have been for some time a combination of autologous graft, connective tissue grafts, together with different surgical approaches. But today, the advent of soft tissue substitutes perhaps may achieve similar outcomes without the need of harvesting the autologous tissue from the patient. This is something we will basically discuss today. The other relevant clinical problem is to apply these technologies in the area of implant dentistry. Here there are several clinical problems that have been treated with this technology, like for example, lack of keratinized peri-implant mucosa, also lack of peri-implant mucosal thickness, and of course the problem of peri-implant soft tissue dehiscences. As you can see, these are different clinical problems that require different interventions and probably require different materials. The current state of the standard of care, the state of the art for treating these problems, basically, as you can see, for the lack of keratinized peri-implant mucosa, we normally utilize the free gingival grafts. However, for the lack of peri-implant mucosal thickness, we mostly utilize connective tissue grafts from the tuberosity, thick connective tissue grafts, because the goal is to increase the volume. And to treat the treatment of peri-implant soft tissue dehiscences is also done with connective tissue grafts, but combining with flap procedures that would provide the best possible outcome with more predictability. So you see, even in the standard of care using autologous graft, we use different approaches to treat different clinical problems. Can we utilize soft tissue substitutes to treat these lesions? Of course, for keratinized peri-implant mucosa enlargement, we would need soft tissue substitutes that will withstand a non-submerged application, because they will need to be healed in an open wound environment. Do we have these soft tissue substitutes? For the clinical problem of lack of peri-implant mucosal thickness, we will need soft tissue substitutes that will withstand the pressure of the flap when we utilize them in a submerged application. Do we have these soft tissue substitutes which are volume resistant or pressure resistant when we want to increase the volume? And finally, for the treatment of peri-implant soft tissue dehiscences, we would need soft tissue substitutes that can protect and can work on top of non-vascularized surfaces like implant surfaces and provide a good coverage of these peri-implant tissue dehiscences. Do we have these substitutes? How do they work? How would we need to apply them in a clinical setting? What are the advantages and disadvantages? These are some of the questions that I hope we would be able to answer during this morning. As you can see, we have 3 presentations, and I don't want to take any time from the panelists. So I'm going to present to you the first of the panelists, Professor Juan Blanco, who of course does not need much introduction. He is one of the most relevant speakers in periodontology and implant dentistry we have in Europe. And of course, when we say Europe, we say throughout the world. Professor Blanco.
Yes, Mariano.
Good morning, Juan. How are you?
Fine, thank you. How are you too?
It's a good pleasure to have you in this symposium, and it's a great pleasure to start with your presentation. And
thank you.
I would ask you to share your screen, and while you are sharing your screen, I will introduce to you Professor Blanco is Chair of Periodontology at the University of Santiago de Compostela in the northwest of Spain. And at the same time, he has been past president of the European Federation of Periodontology, of the Spanish Society of Periodontology. He's a very active member in the ITI Foundation. He's been president of ITI Spain, and he is one of the most relevant speakers in broad areas of periodontology and implant dentistry. So Juan, you have the podium, and we are delighted to listen to your presentation.
Thank you very much, Mariano, for your kind introduction. It's really for me a pleasure to be here today. And before starting, for sure, I would like to thank to you and also to the Oral Reconstruction Foundation for their confidence in this meeting, also to Biohorizons and Camlog, and for sure to our dear society, Sepa, and to all the board for their organization. I don't know if you are seeing, if you are viewing my presentation, Mariano. Well, I'm going to go on. My presentation is about the novel soft tissue augmentation materials, talking about biology in comparison with autologous connective tissues. And according to this, I'm going to deal with different aspects. And I'm going to go through different objectives. First of all is the biology of palatal mucosa that we usually use as the gold standard, and why we are using these tissues. Can we have a substitute biomaterial for this autologous connective tissue currently? I'm going to talk also about this novel porcine-derived acellular dermal matrix, and finally, I will go through with several clinical cases. Talking about biology of palatal mucosa, I have to say that there are different places in the palatal mucosa where we can take this connective tissue. Can be in the anterior zone, posterior zone, coronal part, or the apical part. But we have to say that in a closer vision, that we are going to have different tissues, the epithelium in one side, in the surface, and also beneath this epithelium, we are going to have a connective tissue. But clearly, we can distinguish in this connective tissue two layers. This one layer that is immediately below the epithelium, and this other layer with different characteristics from a histological point of view. As you can see here in this image again, we are going to have here a connective tissue, a dense connective tissue that is composed of a collagen that are distributed irregularly, and this is called the lamina propria. And below this lamina propria, we are going to have a loose connective tissue that is composed with non-so-hard collagen fibers, and also some glandular and adipose tissue. If we talk about histometry, important to say that we have a different mucosa thickness in the different patients. And this is important because this is going to influence in the different layers that we have in our patients, in our mucosa. Probably we are going to have a mean mucosa thickness around 4 millimeters with epithelium that is around 0.35, 0.5 millimeters of thickness. And also the lamina propria is around 1 millimeter of thickness. And this is important because if we want to take only this lamina propria for treating our patients, we have to bear in mind that the thickness of this lamina propria is around 1 millimeter or up to the most 1.8 millimeters. On the other side, important to say that the composition of the connective tissue also is important. We know that in every connective tissue in our body is composed of two components, the cellular component and the acellular component. And in the cellular component, in the gingiva and the palatal mucosa, particularly, we are going to have fibroblasts. And these fibroblasts are the ones who are going to produce the extracellular matrix. And this extracellular matrix have fundamentally proteins in the form of fibers. This is particularly the collagen, and also an important ground substance where some proteins are inside. such as the glycosaminoglycans, the protoglycans, and also the glycoproteins. And these proteins are very important because they are going to be able to act in a different ways to the different cells that we are going to have in the connective tissue. And also, not only the proteoglycans, but also these glycoproteins, such as the fibronectin, they are going to be able to enhance cell motility and also to stimulate cell proliferation and also differentiation. So this kind of proteins inside this connective tissue is very important to induce some modifications in our epithelium later on. As is already published in classic literature papers, such as the one by Thor Karin, that he stated that it is suggested that the specificity of this epithelium is genetically determined. And this is genetically determined by the connective tissue that is below or underlying this epithelium. Also, in another paper by the same group, they stated or they indicate that the gingival connective tissue is capable of inducing the formation of a keratinized gingival epithelium. So the information is in the connective tissue. But at the same time, we have to consider the different layers again. And the different layers, they are going to say us that there are some layer that is called the submucosa that is rich in fat, that is important to eliminate it before going to the clinic, because this submucosa is going to act as a barrier both to diffusion and also vascularization. And therefore, it should be removed before going for grafting. And also in this outstanding paper, these authors have compared these two soft tissue grafts, the one that is very close to the epithelium and the other one that is more close to the submucosa. They split this graft taken from the palate, and comparing these two pieces, place these two pieces around the canine, and the results after the surgery, they stated that deep palatal connective tissue does not have the potential to induce the surrounding non-keratinized tissue. However, sites receiving the epithelial connective tissue, this means the connective tissue, the lamina propria, showed histologic and biochemical characteristics of keratinized mucosa. So this is also summarized in this literature review by Anton Skulden, that is also is one of our panelists today, that they state and they summarize this review in that the tissue specificities of the gingival, alveolar, and palatal mucosa appear to be innately and not necessarily functionally determined, and that the deep palatal connective tissue may not have the same potential to induce keratinization as the palatal connective tissue originating from an immediately subepithelial area. So we can see that probably there are some places where we can obtain a better quality connective tissue, let's say a thicker lamina propria, but probably most important than the place of taking this palatal mucosa is the way we harvest this mucosa. Bear in mind that we have to take particularly the connective tissue that is subepithelially. So the way we are going to obtain our graft, more probably than the place we are going to take it, is more important. So please remember then the connective tissue that really importance for going to a plastic surgery in our patient is the one that is closer as possible to the epithelium. And if we take this to the clinic, we usually use this kind of techniques, and where we are going to use this connective tissue to improve the healing of this coronally advanced flap in this case, and where we can obtain clinical results, clinical outcomes, like the one you can see here in the right corner. Also, we have to say that from a clinical point of view, in the different meetings, in the different workshop, in the different consensus, it was stated that the predictable root coverage is possible for single and also multiple tooth recession defects, but with subepithelial connective tissue procedures providing the best root coverage outcomes. Let's go now to the biomaterial as soft tissue substitute. We all know that we still don't have the right biomaterial to be used daily in our daily practice and to act as a substitute of this connective tissue. But we also know that these substitutes need to have some characteristics. And also we have to understand that these biological scaffolds are going to be different one to another one, depending on the source of tissue and method of processing. We have to take a look to this outstanding paper also. Is a review of the different extracellular matrix-based scaffolding technologies. And according to this paper, there are two important matrices. The one that come from the porcine. So these are xenogenic collagen matrices. They are porcine-derived, non-cross-link, cross-link, or even cellular dermal matrices. But these dermal matrices, they have removed all the non-collagenous proteins and cells, so results only in a 3D stable matrix. But if we go to the allogenic collagen matrix, these are the cellularized human dermis that are obtaining from human skin, we not only have these scaffolds, but also we are going to have some biologic cues in this matrix, human derived matrix. And these important cues probably are going to enhance, to increase the migration, proliferation, and the differentiation of the cells. In fact, there is an interesting paper where they compare and analyze biochemically and also physically these human dermal matrices, where they could find different proteins in these matrices. So probably these matrices can act with these proteins, not only the soluble proteins such as the fibronectin and laminin, but also these growth factors as biologic cues. And this is an important issue when we translate all of these concepts to the clinic, because we can obtain good results with these porcine collagen matrices, but these are going to be inferior to the autologous connective tissue. And there are some papers currently that they are comparing this extracellular dermal matrix, in this case the allogenic one, that the results in terms of root coverage, they can obtain similar attachment results when they compare to the connective tissue. And there are also another papers where they obtain similar results. However, the connective tissue group obtain a significantly greater increase in keratinized tissue. In fact, there is a recent Cochrane review where they stated, the authors, that acellular dermal matrix grafts appear as the soft tissue substitute that provide the most similar outcomes to those achieved by subepithelial connective tissue grafts. And what about this novel porcine-derived acellular matrix? Recently has appeared in the market, this novo matrix, probably 1 year ago. And the characteristics of these novel metrics are very similar to the dermal metrics coming from the human skin. And it has the same 3D organization from a mechanical point of view and from a physical point of view, but also they are going to have some proteins, these glycoproteins, such as the fibronectin and some proteoglycans that probably are important, such acting as these biologic cues. For sure, they are going to have also this collagen and also these elastin fibers. And the characteristics from a clinical point of view is very easy to use. These new materials is pre-hydrated, is homogeneous, the thickness of almost approximately 1 millimeter, and is not oriented in terms of polarity. We can use it from the different side, and important to say that supports a positive immunologic response and regeneration as seen in some preclinical in vivo studies. In this sense, I have to talk about probably this first paper that has been very recently published. Is a paper that is done in the Beagle dog model, and they have compared in the different time points, they have compared two different matrices. Combined with coronally advanced flap to treat recessions that they were produced by the authors. And the outcomes that they have evaluated are root coverage, soft tissue thickness, local tissue reaction, inflammatory response, tissue integration, and also remodeling. And the results when they compare these two membranes are very clear, where they could find a statistically significant difference between these two materials, particularly when they compare in time the root coverage between 6 weeks and 10 weeks in favor of this new porcine-derived matrix, and also in the thickness of the evolution of the thickness of the flap, in terms of that the test group provided greater thickness at the end of the follow-up period. Recently, also by our colleague Anton Skulden in his group, they have compared. I'm not going to talk about a lot about these two papers, because I'm sure that Anton is going to explain them much better than I'm going to do it. But they have compared different kind of membranes, as you can see here, according to the release, absorption, and release of growth factors first, and then how they can enhance the bone healing potential using these different membranes. And the results were in favor of this hydrated cellular dermal matrix that is the new Novometrics metrics. And let me finish with two clinical cases. This is the one typical case with recessions, soft tissue recessions, and multiple soft tissue recession in our patient, where we have to clearly mark the cement enamel junction to measure the different height of the different recession. And according to the paper by Zucchelli and DeSantis, we go through this coronally advanced flap that is done full split in the different layers. And we lift the flap, we prepare the root surfaces, and finally we go with this Novometrics membrane, trying to cover everything. But before going to cover this membrane, why not using this kind of new materials that are appearing in the market, these new fibrin networks that we can use concomitantly with our patients, such as the ALPRF membrane. In this case, authors have used this PRP, because it's important to say that, and according to our paper that we have recently published with our group in our dental school, and also with the group that is led by Angel Garcia and Lydia Armidia, that they work in proteomics in our university, we have analyzed the secretome of these ALPRF membranes. And these ALPRF membranes, we could demonstrate that until 21 days, we can obtain different proteins and different growth factors, not only at day 3, but also day 7 and day 21. And in fact, currently, we are working also in the bone healing influence that these products can produce to the fibroblasts in terms of being faster, in terms of provoking a bone healing in a faster time. So sometimes we use these ALPRF on top of these novomatrix membranes to improve not only as a scaffold this membrane, but also to take the advantage of these proteins that we can have here and that they are released in a slow way. So this is the cover of the membrane, and this is the results after 2 months. We can see here before, and we can see here after. The second case that I'm going to show you is a more demanding case. It's a patient, a young patient, where you can see here that the patient has aesthetic problems on the front area with different size of teeth, different scallop of the gingival margin, and with different aesthetic problems. Also, we can see in the periapical x-rays, this is the number 13, the implant in the position of number 12, the number 11 with an apical problem, the number 21 with an apical problem that includes the implant in position number 22, also a problem infection on top of the number 23. After several surgeries, we could obtain this result. This is the provisional, and you can see here 2 new implants. But still, we have a problem that after modeling with the provisional prosthesis, the restorative dentistry dentist, this is the better result that he could obtain. So finally, we tried to increase the volume in terms of horizontally and also vertically. We lift a partial thickness flap in the vestibular aspect and also a partial thickness flap in the crestal part, as you can see here. So after doing this, we went for a novomatrix membrane. We fold it, we suture, and we install it inside the vestibular aspect and also on top of this edentulous gap. We suture the membrane over here, over the palatal aspect of the flap, and this is the final suture, the final aspect after suturing everything and after increasing the volume. And this is the result. After 1 month of healing, we can see the evolution of the patient. This is after the bone surgery, after extracting the implants that the patient had before, and also solving all the infections. And this is the result after using these membranes, waiting for the final prosthesis after modeling this increased gingival height that we could obtain. So with this, I finish my presentation. Before finishing, I would like to announce you this new date for this symposium, that this symposium should be held last weekend in this year, the 23rd of October, but we have to move it because this coronavirus problem that we have worldwide, and this is going to be celebrated in Santiago, the 17th, 18th of September next year. And I would like to invite you all to at least listen this symposium, this Congress, from an online vision that probably we are taking an important experience with this kind of new procedures for doing these symposiums and congresses. And with this, I finish my presentation. I give the word back to you, Mariano.
Thank you very much, Juan. Excellent presentation, beautiful cases, and a great start to this symposium. Let me ask you one question. I mean, in the development of mucogingival surgery and also soft tissue surgery around dental implants, we have learned to use different harvesting sites, different thickness of connective tissue grafts, different origins of the grafts that we take, with the advantages that you have alluded in your presentation. However, with the advent of the soft tissue substitutes, we basically tried to use one for all, one substitute to do all the different indications. So my question is, do you think we should have sort of specialized soft tissue substitute with different properties, different characteristics for the different indications, or with the technology we have so far, we can cover all the indications?
Well, I think from an ideal point of view, it would be better to have only one thing to use in the different clinical indications. That's clear. And if we have to choose in this way one of the grafts, for sure today is the connective tissue graft, the autologous one, no doubt. But in terms of substitutes, I would say that, and probably with the improving in the research and in the development, probably we are going to be able to find this ideal substitute, because we probably agree that we need a scaffold and also we need molecules acting as biological cues. And probably the most graft substitute that we have so far, considering these characteristics, is this new one.
Thank you very much, Juan. And once again, great presentation. And now we are going to move to the next speaker, please.
Thank you.
Good morning, Anton. How are you? It's a great pleasure to have you with us.
Good morning, Mariano. Good morning, everybody. I'm very honored to participate in this symposium.
Well, of course, Professor Sculian doesn't need a big presentation because he's one of the top leaders of dentistry in the world. And I would ask Tony, while I am doing the introduction, that you shared your screen. Professor Sculian is the head of the Department of Periodontology at the University of Bern in Switzerland, where he also acts as the executive director of that institution currently. Professor Sculian is one of the most prolific researchers we have in dentistry. He's published more than 400 scientific publications, and he is one of the top rated scientists in terms of impact factor and also in terms of contributions which are leading dentistry in the world. He's been president of the EFP, he's been president of the Swiss Society of Periodontology, IADR Periodontal Research Group, a vast experience in education and in research. And with that, I give you the word. Anton, it is a great pleasure to have you with us in this symposium. Thank you very much.
Thank you very much, dear friends, dear Mariano, for this introduction. And in the next couple of minutes, I would like to provide you the biologic and clinical rationale behind the use of innovative materials in soft tissue regeneration. And I would like to discuss with you some of the indications for treatment, some of our treatment goals, some of our philosophies, how we treat various types of defects, and then to share with you some of our new data that we very recently published. And then we can come over to some conclusions. And I would like to start my presentation with some cases, because the majority of my cases that I treat and are referred to us are cases, as you can see it in these slides. They are patients that exhibit severe loss of soft and hard tissue. And in these cases, they exhibit difficulties in cleaning, plaque accumulation, and in certain instances, this may aggravate and may even lead to pocket formation. And my aim as a clinician is, first of all, to help restore the periodontal health, to enable cleansability of these areas, to prevent further attachment and bone loss, and of course, to reestablish this tissue environment. Obviously, if we ask the question, in which situation is it easier to clean, probably all of you would agree that the situation to the right is more favorable. So summarizing our indications, first of all, I would like to help my patient to clean, to prevent gingivitis, and of course, root caries. Of course, to improve aesthetics, but the majority of the cases are located in the lower jaw. So there, dear colleagues, the aesthetic is not the main issue. And of course, in some cases, we may also treat hypersensitivity. So if I would summarize our goals, I would like to help to optimize plaque control. Of course, if possible, to regenerate completely the lost tissues. In other words, to obtain 100% of coverage. To avoid, in the same time, niches, that means residual probing depths exceeding more than 3 or 4 millimeters. To enhance regeneration, and to obtain a tissue that is favorable in terms of blending and color, but also to avoid scar formation as much as possible. And here, one example, you see one patient that I treated more than 11 years ago. And after 8 years following soft tissue augmentation and recession coverage, we have a natural appearance of the tissues and 100% coverage. So if we look now at our treatment concept, we always have to focus on biology. And I think this is very important if we are dealing with regenerative approaches. What we aim at is to help the body, to help the defect to heal. We will have a blood clot formation during our surgical intervention, no matter whether we are dealing with an intrabony pocket, a furcation defect, or a recession type of defect, but the phases of the healing are always the same. So what I aim with my material, with my surgical approach, with my postoperative care, is to stabilize the wound, to stabilize the blood clot. And in fact, for this reason, we like to use flap designs that aim to enhance wound stability. And if possible, I try to avoid vertical releasing incisions as much as possible. Not always, but I would say 95% of the cases. Then we would like to use some biologic materials that will promote periodontal wound healing and regeneration. And in many cases, if we have these patients with recessions, especially in the mandibular anterior area, the tissue is very thin. It is very challenging to stabilize this tissue just by using the flap. So we need some additional materials. And Juan Blanco very nicely presented the autogenous tissues. And this is still the gold standard. However, we try to improve our skills and our philosophy and our biologic rationale by integrating soft tissue replacement materials that have comparable characteristics than an autogenous tissue, because we would like to help the body and to help the defect to heal, increase tissue thickness, and stabilize the wound. And of course, the suturing technique and the flap management are critical. Obviously, if we have these situations where we have this probe shining through the tissue, it is very challenging, and we need to increase the thickness. Otherwise, with a flap alone, probably we will have a relapse very fast. So we have elaborated and worked on techniques that have been also depicted by other groups. And we prefer to use techniques where we do not cut the papillae. And one example is the tunnel approach in different variations. For example, the laterally closed tunnel that we published some years ago, especially for deep defects in the mandibular area, are very, very successful, especially for single recessions, because we have a very good stability of the wound, we avoid vertical releasing incisions, and we have a very limited change in the depth of the vestibulum. Let me share with you some cases in order to have the idea on how we treat these particular cases. You see, in this particular situation, we are facing a quite deep recession, almost until the apex. The patient has difficulties to clean, and she also exhibits a pocket. So in such a case, I do not cut the papillae because I want to stabilize the wound as good as possible. We prepare a so-called tunnel approach. We prefer to start in a full thickness approach, and then we release the fibers, preventing any rupture of the papillae. And then at the very end, we release the fibers and we approach the two edges of the tunnel in order to be able to suture them over the facial aspect of the tooth. In this particular case, we use connective tissue that was completely covered. And please observe the healing after about 3 years, indicating a very nice clinical outcome. And we are very successful with this technique when we use, of course, connective tissue graft. And in multiple defects, we also extended the same procedure. And let me share with you another case that I treated more than 10 years ago in the maxillary arch. And please observe the phases of the treatment. We prepare the tunnel. I do not cut the papillae. And at the very end, we use the biologic material. We may combine certain biologic materials like enzymatic proteins, hyaluronic acid, maybe PRF, with our autogenous tissue. And after fixing the autogenous tissue, I move the flap coronally and suture it in a stable position. And this will result in a stable outcome. And this is one example after 10 years, indicating a nice aesthetic and also increase in tissue thickness. And we are able to successfully treat multiple defects with these techniques. Let me share with you a short video just that you understand our technique. In this challenging case, the lady had multiple defects. She had difficulties to clean. And in this particular case, you will see that we need a lot of autogenous tissue. And the main aspect here is to have the wound stability. And for this reason, I do not cut the papillae, but of course we need some tissue. And as you can very nicely see, we have a very large distance. And this distance comprises the area between the first premolars in the mandibular area. So we need a very long graft, probably a mere tuberosity graft that is excellent, of course, is not enough because we need a very long graft. Of course, we can harvest the graft. However, it is obvious that the morbidity for this patient will increase, no matter how skillful we are. And I think this is one reason to think at also some other options. And you can see the harvesting technique. I fully agree with my very good friend, Juan Blanco, that we try to harvest the graft as close to the epithelium as possible in order to make sure that we have a connective tissue that is able to promote the keratinization process. But please observe that this harvesting is not very pleasant for the patient, and for many clinicians, it is also challenging. And don't forget that we have situations where we are facing multiple defects in the maxillary arch and multiple defects in the mandibular arch. And we may need to harvest several times grafts, and especially if the anatomy of the palate is challenging. In other words, if we have a so-called flat palate, we may get into troubles because the palatal artery is running very close to the teeth. And then, of course, we need to pull this graft into this tunnel. And please observe that the defects are very deep. In fact, what we see from a clinical point of view, at the first site, where before we raise the flap or the tunnel, it is always less deep or less complex than the situation that appears after we have prepared our tunnel. So that's why I like to use also some regenerative materials, like, for example, some proteins, like enemymatics proteins. Maybe we may have some other growth factors that are positive for the healing process. And of course, it would be excellent to have also some biomaterials that are able to absorb these proteins, to keep them in place, and to release them over a longer time period. So it is very challenging, also from a technical point of view, to pull this long connective tissue graft into the tunnel, because it is very slippery, and if we make one mistake, we forget to have these pulling sutures, we may even lose the material very fast. So it is not very easy from a technical point of view to include this material in the defect and to fix it. But please observe the suturing technique that I think is very important for any type of graft if we want to stabilize, in fact, this wound. Because with our sutures, we are going to make the graft stable. And if we have a stable graft, definitely we will have a very stable blood clot. And therefore, the entire surgical technique, it is very, very important for the final outcome of our intervention. And then we just close this tunnel either with a lateral approach, or we combine it with a coronally movement of the flap, making sure that we are not touching the graft with the tip of our needle, and we are able to approach, in fact, the edges of the wound. So, in fact, this is our surgical procedure, and you will see that we can have a very nice closure, especially in the cases where we do not have very wide attached keratinized tissue. So When we move the lip of the patient, of course, all the area needs to be quite stable. So I would like to share with you now the outcome of this case after a couple of years. And you can see that the soft tissue regenerated quite nicely. But keep in mind that this is a quite challenging intervention. So we started to use and to work on different materials that are able to compensate this lack of autogenous tissue. And we have some biological principles that are needed in order to have the appropriate material. The material, of course, should be biocompatible, fully biodegradable. It should provide a structural support. It can be cross-linked, but we have also a number of non-cross-linked materials, and it should facilitate blood clot formation and attract cells from different areas of the wound. And these cells have the capacity to reform the soft tissues and to bind in the same time very efficiently different types of growth factors that influence wound healing. So we started a number of studies, and I would like to share with you two very recent studies published this year in the summer. So what we wanted to know, whether there are differences among these collagen matrices, which collagen matrices can be used, and all these collagen matrices had a porcine origin. So we took a non-cross-linked collagen matrix that was abbreviated as NCM, a sugar cross-linked collagen matrix abbreviated as CCM, an acellular dermal collagen matrix supplied in a dry form, and the prehydrated acellular dermal matrix that also was abbreviated as HADM. So in the first study, we looked at the various types of growth factors that are absorbed in these matrices, and we wanted to know for how long time they stay in these matrices and are released. So in fact, we tested different types of growth factors that are commercially available. We can order them. TGF-beta, FGF2, this is fibroblast growth factor, PDGF, a very important growth factor for the wound healing, GDF5, and BMP2. And please observe the differences in terms of the absorbed protein in percentages and the total protein release up to a period of 13 days. And if you compare the different matrices, we can see that all of them are very biocompatible. They are able to absorb the matrices. However, there are some differences. And if we look at the 4 different matrices, we can see that in terms of TGF-beta1, FGF2, for example, and PDGF, we have some differences among the groups. And especially if we have a look at the BMP2, we have in this last table a difference that favorizes the hydrated collagen matrix. Then we looked at the release of different growth factors. Also, we looked at the release of enamel matrix proteins. And again, you can see the tendency. What we have seen in all these matrices is that we have 2 peaks. One peak after a couple of hours, but then the second phase that is very important is after a number of days that you can see them in the later slides. But please observe the amount of protein release in phase 2. And after 1 hour, we have a very high peak in the hydrated collagen matrix. And then we looked at the release of FGF2. And again, you can see the different bursts. And all four matrices were successful. However, we have seen that the FGF2 release amounting was at 3 hours in the hydrated matrix, but also the other matrices were quite successful. Now, when we look at the PDGF, we also see again the same trend, and we can again see that we have again the phase 1, and at 1 hour we have the phase 2, and that several days you will see later also this trend. So when we look now at the FGF5, we can say that all four matrices were quite successful. However, at 3 hours, the hydrated matrix showed a higher amount of this protein release. When we look at the BMPs, we see now at 1 day, at 1 hour, at 3 days, at 9 days, we see these peaks. And please observe that we have this peak also in the hydrated matrix after day 9, and also the non-cross-linked matrix was quite successful. What we observed, interestingly, in this hydrated matrix, that we had an additional third peak, and this was quite interesting for us. So in summary, we can see that we have the potential with these matrices to absorb the growth factors and to release them over a certain period, assuring the long-term effectivity of these materials. So if we look at the differences in terms of various growth factor releases, interestingly, if we look at the hydrated matrix, we had with this matrix kind of increase in BMP2 factor absorption and release even over 9 days, indicating that this may be quite relevant in the clinic, maybe for bone formation as well, or bone augmentation procedures. Then in the second study, we wanted to look also at the effect of these matrices on the different cells, because we have two types of cells that are critical. We have the peroneal ligament fibroblasts and the fibroblasts coming from the connective tissue of the flap. And please observe the different assays that we have done in our laboratory. We have, of course, the control. Then we looked at the non-cross-linked collagen matrix, at the cross-linked collagen matrix, the dry acerrodermal matrix, and the hydrated one. And if you look at these colors at these plates, you can see that we have a very nice increase in the amount of cells. The cells like these matrices. However, the cell density was the highest in the hydrated collagen matrix, and also the cross-linked collagen matrix performed quite interestingly, quite well. However, all four were much better than the control. You see how we did the experiments. We placed these matrices in this media, and then we looked at the cells. What I can tell you is that it's very important that even the hydrated matrix is washed, because if we don't wash these matrices enough, then we may have a deleterious effect on the cell vitality. So this is maybe a very important tip for the clinic later. And then we looked also at some wound healing assays. That means we have standardized possibilities to have some scratches in these cell cultures. And then when we place the different matrices, we can look how fast these cells are repopulating these areas again. And again, if you look at this wound healing assays, then we can again see the same tendency. The hydrated collagen matrix and the crossing collagen matrices perform significantly better compared to the two others. However, all four were significantly better compared to the control. And again, you can see the proliferation of primary peroneal ligament fibroblasts and oral fibroblasts on these matrices. And these two matrices were quite interesting. The cross-linked and the hydrated always with a higher peak and a higher proliferation rate. And then in another experiment, we looked at the wound healing property, and we looked at the increased expression of proliferative marker genes that influence cell growth. And I don't want to go in all details, but you can clearly see in these bars the tendency. In all this gene analysis, it turned out that the hydrated matrix provided very good outcomes. And when we look now at the increased expression of adhesive marker genes, we looked and found out again similar tendency, but of course all four matrices were quite biocompatible and provided this healing. Then we looked also at the increased expression of wound healing related genes, TGF, beta-1, FGF2, etc. And again, we have also some differences among the matrices, but look at the tendency, and the tendency shows positive effect towards all four matrices. Also in terms of inflammatory matrices, we may have some differences. Sometimes we have more inflammation with some of the matrices, like the dry matrix, for example. But as a tendency, all four provided much better outcomes than the control. So let me have a short summary about these findings. We can see that these matrices are quite successful in serving as a scaffold for growth factors, also for cells. We have certain matrices that may trigger a stronger migratory response. For example, the cross-link matrix and the hydrated, especially the hydrated matrix, and the cell grown on the cross-link matrix and the hydrated matrix demonstrated significantly higher proliferation rates compared to cells grown on cell culture plastic. And I think that we have some materials in our hands that may be very relevant for the future, especially for enhancing wound healing in difficult cases, or maybe being combined even with some cells or growth factors. So what is now the clinical relevance of this? Having made my experience in the lab, I tried to treat also some patients, and I don't have yet 6 months data, but let me share with you some practical aspects. This is a patient that was referred to me for recession coverage, and the surgical technique is the same that you have seen with the connective tissue graft, preparing the tunnel, using the matrix. So based on our experience in the laboratory, we always wash this matrix several times, because we observe that if we do not allocate enough time to wash the matrix, then it has a negative effect on cells. However, if we wash it long time, then has a very positive effect on the cells. And maybe this is something that we have to follow up in further clinical settings. So the material can be used very easily. It feels like a connective tissue graft. However, we do not need the sutures to pull the material in the tunnel, because we can push it very nicely with our instruments, and it has also mechanical stability. So from a clinical point of view, it is a material that is quite pleasant to use, resembles very closely to autogenous tissue, but on the other hand, it is easier to apply. What I can recommend to you, please completely cover the matrix. Don't leave it exposed, because then we will have a very nice wound healing. I hope that in the next coming months, I can also share with you some 6 months results with this material. But as a first impression, what I can tell you is that, of course, when we use the tunneling approaches, we may be very successful. However, the collagen matrices may represent a future option to replace connective tissue. And even if you are not able to completely replace connective tissue grafts, these materials may serve as scaffolds for biologicals, or they can be combined with maybe a small strip of autogenous tissue. The first clinical results and the clinical management of the cases I have treated seem to indicate an excellent tissue response using the Novo matrix for recession coverage. And these first clinical impressions, because this is not a clinical study, of course, appear to support the outcomes that we made in the preclinical studies in the laboratory we presented in the 2 papers. And with this, dear colleagues, thank you again for listening to my presentation, and I'm available for any further questions. Muchas gracias.
Thank you. Thank you very much, Professor Sculian, for your superb clinical demonstration of how you can deal the very difficult multiple anterior lower recessions. Let me ask you one question. We have seen in the first part of your presentation that you utilize a combination of connective tissue grafts with proteins, either enamel matrix proteins or other biological components. And we have seen in the second part of your lecture these beautiful experiments in the lab where you have added biologicals, and you have looked at how this matrix absorb those biologicals and release them. So my question is, looking at that research and your clinical experience, do you think we should always combine biologicals with the new developed soft tissue substitutes to enhance their clinical properties?
That's a very good question, Mariano. And I think that, first of all, we have to have some randomized controlled clinical studies that we look at clinical parameters. And if you want to have some impression and some data about these matrices, in the very first step, I would just compare this material with a connective tissue graft without adding any additionals. Because if we add PRF or EMD or whatsoever in a clinical setting, I mean, then we have already another variable. And I would go for a simple clinical design. Either we have a coronal advance flap or tunnel or whatever you like, using the collagen matrix and compare it with the coronal advance flap alone, or we either use the same setting and we compare it with the connective tissue graft clinically. And then we have to see how it performs, because the gold standard is still the connective tissue graft. And then I think we can elaborate whether to combine it or not with a biologic material. But for this, I would also go in a preclinical study in an animal model. And I would like to see whether this approach in combining the matrix with the growth factor, with enzymatic proteins, or with some other biologics may indeed promote periodontal regeneration to a higher extent than the matrix alone. So I think it is very difficult to give an answer, but I would answer one question with one study. So if you ask me whether I would advise to combine it, I would not combine it at the very beginning. First, I want to make my experience and to have clear questions that are answered with one study, and we have to make our homework first. But the first data that we have are really promising because they can be used as a scaffold. But it is a long way from the lab to the clinical situation. So I think we have to make the homework, and then we can discuss it further. But this is my personal philosophy.
Thank you, Tony. Very clear. Thank you very much. So now we are going to move to the third speaker, Dr. Andrés Pascual, and please. Well, Andrés Pascual is one of our young stars in Spain. Probably he's not that young any longer, but he is a periodontist that was trained at the University International of Catalonia and stayed there to do his PhD, and further now he is the co-chair of the postgraduate program at that university in periodontology and implant dentistry. Dr. Pascual is also one of the members of the board of the Spanish Society of Periodontology and is a prominent clinician as well as a researcher. So Dr. Pascual is going to speak on how to integrate clinically the use of these procedures and what is the step-by-step application. And without any delay, please, Andrés, the floor is yours.
Mariano, good morning. Good morning, everyone. It is, I think it's the first time that I'm presented by Dr. Sanz. So this morning it's going to be something I will always remember. Thank you for the presentation. Thank you for the nice words. And thank you for saying that I'm one of the young stars, because as you mentioned, I'm not that young anymore. I'm still young, but not that much. I would like to thank also the Oral Reconstruction Foundation. It is a big honor to be one of the participants among the speakers that are lecturing this morning. And of course, I will do my best to offer my knowledge in the use of substitutes for the palate. It's been 17 years since the first time that I used an acellular dermal matrix, so I think I have learned something from a clinical perspective, and I will try to show my point of view. So I will go for sharing my screen. Share. Okay. Can you see it properly?
Yes, indeed.
Okay, perfect. So to start, I would like to say that I'm not going to go only a step-by-step situation. I would like also to talk about concepts that we need to understand and to know. And first of all is that when we do a periodontal therapy, we need to understand that the main aim will be to preserve and maintain. And today we also include the reconstruction of not only the dentition, but the periodontum and the peri-implant tissues. But we can't forget what are the perspectives and the perceptions of our patients. So we need to respect also the aesthetics and their function. And to do this, we need to understand pretty clear which is the treatment that we're doing, in which way we will take this. And of course, the first thing that we need to do is it's a proper diagnosis. We need to understand the situation, because even if we believe this is basic, there's people that still don't pay enough attention in differentiating what is a pathology and what is health. And that is a major fact that we need to understand. Especially, we need to understand the anatomy in our patients. We need to understand what is the mucogingival junction, because when we talk and when our aim is to reconstruct the periodontum, we need to understand what is the keratinized tissue, what is the attached gingiva, and we need to understand what is the free gingiva. These are major concepts that needs to be completely understood by everyone who would like to do a surgery in the field of mucogingival. And also we need to differentiate what is a mucogingival defect from what it is a mucogingival problem. In the slide that we have now on the screen, the left patient definitely has a mucogingival defect. It has some recession. It has a very scarce amount of keratinized tissue, but everything looks pretty healthy. But in the picture on the right, as you can see, it's pretty noticeable that on the central incisor, there's not only a recession, but it's also chronic inflammation related to this recession. And of course, as it was mentioned by the previous lecturers, there is also some hypersensitivity. So the patient has a couple of complaints about this area. Why is this important? Because until now, we knew that the mucogingival defect was not supposed to be treated, and mucogingival problems had an indication for treatment. And that was mentioned in the World Workshop of Periodontology in 1996. But in a recent, but as I mentioned before, in cases like this, and if we follow the results of a very recent meta-analysis by Chambrone and Tatakis, they mention that in these kind of cases, even if we don't have a mucogingival problem, but only a mucogingival defect, we have an odds ratio of 2.43 of possibilities of increasing the depth of the gingival recession. And also, if we have a single defect, we have a 2.16 odds ratio possibilities of increasing the number of gingival recession defects in our patients. So even if we have patients with no mucogingival problems, we must consider that even under good oral hygiene, these patients might have the probability of progressing in a long-term follow-up and might need to be treated in a most previous stage and not waiting until the appearance of deeper problems. And we also need to understand why our patients have those recessions in their mouth. So which are the causes for these factors? We understand that there are some predisposing factors, which are mostly related to the genetics or the anatomy of the patient. And then we also have the precipitant factors, which are more related to the habits of the patients, the way they brush their teeth, or if they have received some sort of a iatrogenic dental treatment, etc. And that's very important because this needs to be understood and controlled before we decide to do any kind of treatment. And of course, we need to understand the phenotypes of our patients. We know that there are three kinds of phenotypes, but we also know that even in the thick, flat phenotypes, it's not so common to see recessions and mucogingival problems. We know that 2/3 of the population have or a thick scallop or a thin scallop phenotype. And in those phenotypes, it's quite popular or common to have recessions. And of course, the prevalence of these recessions, it's common between the population. And the literature has shown that around more than 50 to 60% of the individuals over 50 to 60 years old have at least one recession of 2 or 3 millimeters in their mouth. So it's quite popular to see patients in our office with these defects. And that's not something that I have said, that's something that it's published and that has been mentioned in the literature for the past couple of decades. And also we need to understand that there are some treatment considerations that we need to follow and that we need to understand. And that comes to the fact of what are we looking for. And today we need to understand that if we want to evaluate the clinical result of a periodontal plastic procedure, we are not only looking for covering a recession, we also are looking for enough quantity of tissue, and of course, the quality of the tissues that we are obtaining in the area that we are grafting. And we need to understand also which are the parameters of success that we want to evaluate. Of course, as I mentioned, we are always looking for a complete coverage of the recession defect, but we also need to understand that it's necessary to have help around that recession. So we want minimal probing depths associated to that root coverage. And today we don't accept these results unless we have good aesthetics related to the procedure that we perform. And not only because we don't like scar tissues, we don't like different colors or shapes of the gingiva, but also our patients are not happy when we do that types of surgery where the gingiva doesn't look or doesn't have a natural appealing. And that's what they really consider as success. And then we can pass straight to what are the clinical key factors that we need to take in account. First of all, remember the classification of the recessions, as Professor Sanz mentioned and in his introduction. We have a recent, well, not so recent because it was presented in the year 2011, but we understand that we need to use the Cairo classification in order to understand how are the predictability of our procedures. This classification is based on the detection of the interproximal CEJ and the buccal CEJ. And of course, it's also based on the evaluation of the loss of interproximal clinical attachment. And this is a real factor that will give us the prognosis on how far we can go with the root coverage or with the increasing of the soft tissues around the recessions. And of course, as Professor Sculian mentioned, we need a successful integration of the graft that's going to be mandatory for achieving good results. And for this, we need 4 key factors to achieve. And first of all, it's going to be the blood supply of the graft. If we don't have a good blood supply, we will never achieve the revascularization of the graft. We need also to prevent bacterial infection in the area where we're treating, and that can be related to the type of procedure that we choose, the type of surgical technique. It is also very important, the stability of the wound during the whole healing period, and that means for an autograft like connective tissue or a free gingival graft, we're talking about 15 days. But if we go to a substitute, we know that this period is longer, that we're not talking about 15 days, that it's probably more like 4 to 6 weeks. So the stability of the wound has to be longer. And of course, always, if possible, we will prefer a primary wound closure and not a second intention healing. And of course, we have to follow this key points that I mentioned before. We have to understand which of these are related to our patients and which are related to the techniques and which are related to the surgery in general. So when we talk about our patient-related factors, we need to understand that some of them have to be previously controlled, like smoking. We are not going to perform this type of surgeries on patients that are smokers. We also should avoid this type of treatment on patients that have inhaled systemic conditions. Also the genetics, if we know that our patients have no good healing in general, we should consider this as possibilities that can interfere in the healing of our treatment. Oral hygiene habits, we don't want patients with bad plaque control. We don't want inflammation around the tissues that we're working, because that will interfere completely in the healing. And of course, the age, because the older we get, probably the healing might get a little bit impaired. Site-related factors, these are factors that can interfere, as I mentioned before, in the blood and the coagulum stabilization. So it is important to understand the depth of the vestibule. especially if we need to advance or mobilize the tissues. We need to understand also the extent and the anatomy of the defect. How deep is the recession? Is it a single recession? Is it a multiple recession? That's quite important to understand. Also, soft tissue thickness. There are some works presented, for example, the works by, oops, I forgot the last name, but comes out later. By Cortellini, where I mentioned that we needed to have thick tissues in order to achieve good healing in the post-op. Also, the amount of keratinized tissue, this is very important. I will show you some literature later that this will definitely interfere in the healing and the probabilities on the stability, the long-term stability in our patients. And as I mentioned before, the plaque or infection in the areas. And of course, the technique-related factors that will interfere directly into the blood supply and the wound stability. And this is related to different factors, like, for example, the graft volume. We need to understand that we don't need to take huge amount of tissues from our patients, or we don't need to overcorrect in all cases, because the graft volume can also be a limitation in the revascularization. We don't want to use tissues that are too thick. We also need to understand that concerning the surgical technique, the design of the technique will also be related to the operator's skills. So we know, and it's something that we have learned during the training that we received to become dentists, that there is a learning curve for every procedure. So in mucogingival surgery, there is also a learning curve that is quite important. And we need to consider that, because it's the only way that we will understand when are we dealing with flap tension, when are we causing too much trauma to the tissues while we're doing the preparation of the area and the wound bed. If we don't understand the anatomy, we will not know how thick are the flaps. And of course, the incision design. Are we going for a non-incision, non-vertical incisions? Are we going for a tunnel technique? These are all factors that can interfere. And of course, the technique that we're choosing, we know that historically, we have been using classic techniques like the free gingival graft, like the coronally advanced flap. These are techniques that have demonstrated that are between the most popular ones, like the free gingival graft or the connective tissue graft combined with a coronally advanced flap, which is probably the gold standard still today. But we need to understand that when we do this type of techniques, there is a major limitation. And of course, it's the donor area. And the donor area is going to be the palate. And as it was mentioned by Professor Blanco, the palate has some limitations. We know that we don't have all the amounts of tissues that we want. We know that we only have around 31.7 millimeters in length, even if Professor Sculian just showed us a video where he he harvested an incredible long tissue, but we know that that doesn't happen with all the patients. We have to consider that there are some anatomical limitations, and of course, the quality of the tissue is not always the same. And that has been shown in the literature for the last decade in a lot of publications. And the most important thing that we must consider is the morbidity that this causes in our patients. And we know also by the literature that the deeper we go in the palate, the more pain the patients will suffer, and the thinner the residual flap that we leave in the palate when we're going to the most to the area that is closer to the epithelium. We also know that the thinner that we leave this tissue, when it's less than 1.5 millimeters or 2 millimeters, we know that the possibilities of necrosis is higher. So this will cause a higher morbidity in our patients. And of course, that, as I mentioned before, will be interpreted by our patients as non-successful treatment. And we can't forget the possibility of a lesion of the palatal artery. So we have to be very careful with this. And as I mentioned before, we need to understand the anatomy of the areas where we're working. And for that reason, we also need to remember that substitutes are a possibility. For the past 20 years, we know that the different companies and the industry has been working in possible substitutes that can help us in situations where we cannot harvest or we cannot work in our palate. And we know that there are some collagen matrix. We know that some proteins or animal matrix derivatives have been used also as a coadjunctive for root coverage. And of course, the cellular dermal matrix has been in the market for several years, but it has been suffering different modifications. Originally, we used to work with human derivative materials, and today it seems that we prefer xenograft from an animal origin. And it's the case of this new acellular dermal matrix that we have been talking during this morning, the Novo matrix presented by the company Biohorizons. As you can see here, this is a slide provided by the company. You can see in the top of the slide, this is the original porcine connective tissue. And if we go to the processed material, which is the Novo matrix membrane, we can see that the characteristics are pretty much the same. Hardly modifications of the tissue suffers just like slight modifications, and it seems to be related with the results we are achieving. If we compare this to other brands of materials that are in the market, like other porcine membrane matrix, another dermal matrix, or in this case, this is a multi-layer collagen membrane, we can see that there are some differences. Of course, that all these materials are designed to work as a scaffold for the blood clot in the treatment, but the thicker materials or the most stable materials will provide us better stability in the post-op of our patients. And of course, we need to remember that for the surgical approach that we decide to take with our patients. And in here, we can actually spend the whole morning discussing if we want to go for a tunnel technique or if we want to do a coronally advanced flap. And there's still nothing clear in the literature showing us that one technique is superior to the other one when it comes to covering recession. So what it will be the mandatory decision of going for a coronally advanced flap or for a tunnel technique will be on the question of incise or not incise and detach the papillary tissue, because we must remember that in one case, like this patient, we have different type of papillas. And of course, we know that if we have good papillas, long papillas, or wide papillas, we're going to be able to detach them and prepare a good tunnel. But we know that in situations like what we see here in the anterior lower mandible, there are no papillas. So for sure, preparing a tunnel in this area is going to be difficult. And also a coronally advanced flap will be difficult to design because we have some combined recessions with non-recession teeth. So for that reason, we need to think and we need to design or choose the design that we're doing before, based mostly on the papillary tissues that we have. So for this, I will go straight to the clinical cases presentations. I've been working for this with this material for the past 10 months. I have performed only 4 cases, and I will show you 3 of them that I'm very proud. This is the first case. This is a young female patient. She's around her 40s. She is a very stressful, she's a cooker in a restaurant. She's a very stressful person, and she brushes very hardly. And this is probably the result of her intense brushing technique. As you can see here, we have different type of recessions. Mostly of them are type 1. In some areas, we have lost a little bit of attachment in the interproximal area. But what is most important to evaluate here is the fact that, as you see here, in this canine, we practically practically have no keratinized tissue. And here we have only like 1.5 millimeters. And this could be related to the result. I went for a tunnel technique. This is the technique that I normally use in my patients when I do mucogingival surgery. I feel very comfortable. I normally do a full thickness flap until the mucogingival junction, and then I go for a partial thickness flap in order to release the maximum of the flaps and be able to coronally position them. This is just to show you the matrix. In this case, it was mentioned before, it's pre-hydrated, but we need to wash this. And for what we learned from Dr. Scullion, for sure, I will start doing different, several rinses of the membrane to be sure that I have no affections on the cells. I normally trim the membrane around 7 to 8 millimeters in the maxilla and 6 to 7 millimeters in the mandible. So I just, for the picture purpose, I show you the full membrane, but it was trimmed, located. This is the Allen modified suture technique. And as you can see here, this is the patient after 1 week. This is a complete natural healing, very different from what we were used to see with the human derived material. There is no inflammation. It looks actually very, very good. Here you can see the 8 weeks post-op. This is when I normally remove the sutures. I have some recessions, like residual recessions in some of the teeth. But what I did is like I train my patients for oral hygiene habits again. We wait a little bit longer, and this is the lateral views. This is the pre-picture, and here you can see 10 months after the full difference in this mouth. We have no recessions at all in the anteriors, only in the smaller, just like 1.5 millimeters. But in general, it seems that creeping attachment also was part of the deal. This is a second case. In this situation, I only wanted to do a phenotype modification. This was a patient that was in need for orthodontic treatment, but the phenotype was too thin. My idea was not to cover anything because, as you see here, there are no recessions, and the orthodontist asked for thicker tissues in order to work more comfortable. So I mentioned the patient the possibility of doing a graft with Novomatrix. The patient agreed. So this is how it was after cleaning. As you can see here, the patient, due to the thin tissue, it was difficult to control inflammation and cleaning. But even though I was capable of preparing a partial thickness flap, even if you don't see it, this is partial thickness flap. There are some dehiscences and some hidden recessions in this patient. This is the membrane placed in the area. I normally leave the membrane apically to the cemento-enamel junction, never over the enamel in the patient. So, but due to the picture, it moved. I repositioned the flap. I covered. Here you can see the 1 week healing. It looks very, very nice. As I mentioned before, there is practically no inflammation related to this material. Even if you see a white thing here, you're not capable of notice in the picture, but it was thicker than what it was originally. And you can actually notice a little bit here, the presence of the membrane under the tissues. This is a 4 week post-op. And here you can see 8 weeks when I removed the sutures. This is the pre-surgical picture, and this is the 10-month after picture. As I mentioned before, we might not be able to appreciate it properly in the picture, but here, this white thing that you see is not the bone. This is, you can pressure it with the finger and you can notice that this is soft tissue. It's completely white, but this is not bone. This is an increase in the thickness of the phenotype of this patient. And this is my third case. This is an increase of gingival thickness in implant. This patient came to me. The implants were completely out of the anatomical limits of the maxilla. You can see a transparency, the gray transparency. I also prepare a partial thickness flap. You can see here the periosteum actually covering the implant. My idea was not to cover the recession, only to increase the thickness. I placed one layer of a membrane. I felt that it was not enough, so I went for a second layer. And as Dr. Blanco mentioned at the beginning, I fully sutured it. The two membranes were sutured and will also suture to the periosteum in order to fixate it properly. Here you can see the full closure for primary intention in the healing. This is the 1 week post-op, also very nice healing, no inflammation at all, maybe a little bit of redness. This is a 4 week when it was time to remove the sutures. 8 weeks post-op, everything looks very, very nice. The patient was very, very happy with the results. This is the pre-surgical picture, and this is the 10 months post-op. Of course, we have lost thickness of tissue, but as you can see here, there is no more transparency of the implant. Actually, we gained some volume in the area. As I mentioned, I was not looking for covering the recession of the implant. I was just looking for increasing the thickness. I don't know what will happen with this in time, but at least at 10 months, I have very good results, and the patients are very happy with what we have achieved. During the morning, some evidence of the use of these membranes have been presented. I cannot show you direct evidence in some cases for the porcine matrix, but we know that the human-derived material was, from a histological point of view, a very safe material because it was completely, completely integrated to the tissues of the patient. We have this very recent article that was also presented by Dr. Blanco, and they also evaluated the histology of the use of this membrane in an animal model, and they conclude that the material it's very similar to the natural histology of the connective tissue of the patients. So it seems that it's safe to use. But also, as I mentioned during the cases, this is something that I want to mention, and it's the fact that the group of Homley Wang and also another publication where Giovanni Zuccoli is also included, they mentioned the necessity of having at least 2 millimeters of keratinized tissue when we're using these membranes for root coverage, because this is what will give us certain stability and to avoid the relapse of the recession. So remember, if we don't have keratinized tissue, if we don't have at least 1.07 millimeters of thickness of the tissue, and if we don't have 2 millimeters of keratinized tissue, we will probably have a relapse in this type of treatment. And if we use it on our implants, we also need to know that literature has been very clear, showing us that when we're dealing with 1.5 millimeters of increase, we have evidence that this can be stable for at least 12 months. So it seems that it's a safe material to use in these cases. And I also like to finish my presentations. I like to use this article, even if it's not so popular. CASA in 2016 told us that when we want to do root coverage and we want to use a substitute, there is still not enough evidence to provide us what's the best substitute what we have to use. But as it was mentioned during the morning, it seems that we're going on the right road. We are going for the development of better materials that are giving us successful results. So for sure, in the future, if we follow a right diagnosis and a right indication, we will end up having good results. And it's when it comes to my conclusions, what I like to mention always, that we need to do an extensive evaluation of the situation. Please be sure to understand the area that you're treating. Remember that there are some clinical implications. There are going to be some patient-related factors that we need to control before deciding to treat. we have some site-related factors that we need to understand, and we also need to know what are the limitations related to them. And when it comes to the procedure selections, remember that the technique that we choose can also interfere in the results that we are expecting, that there is a training curve associated to every clinician, so our skills will be also mandatory in the decisions that we take, and of course the expected results. Do not expect what you cannot obtain from the treatments that you are providing to your patients, and of course go for the right material selections. If we can use natural tissues like autograft, it's a good option. We know that it's a gold standard, but when we have the limitations, we have to remember that we have some substitutes, but among these substitutes, some of them are better and some of them provide us better evidence than others, and that has to be also mandatory in the choosing of these materials. So this is the last part of my presentation. I will stop sharing my screen.
Thank you. Thank you very much, Andres. Thank you very much, Dr. Pascual. Since we are running a little bit late, let me ask you a short question, Andres. You started stating that you have quite a long clinical experience using human-derived acellular dermal matrix. And now we are discussing the advent of the xenogenic acellular dermal matrix. So in your opinion, with your clinical insight, what advantages the xenogenic membranes could have over the long-term use and clinical experience of the human one?
Well, Mariano, my first impression in this material is that the healing, the post-op healing, it's much better than the human derived material. There is not so much inflammation, and for sure that it's due to the reaction on the cells of the patient. So that's my first impression in general. I don't know what's going to happen in the future. I only have a 10-month experience. There is no human evidence in the literature providing us long-term stability of these materials, but for sure there will be in the next few months. We're actually working in our university in a 1-year study. So I don't know, I hope that we could show evidence that these materials will give us better stability than the human material, because there was also an appreciation and some articles that show evidence that show that the human materials resorb a lot, over 60% from the original volume. So let's see what will happen with these xenogenic materials.
Thank you. Thank you. And we are going to give way to the panel discussion. We have 3 real experts in the field. And once we have thanked our lecturers, let's move towards the panel discussion, please. Well, good morning. Hopefully, everybody is online. Let me introduce very briefly, because we are running a little bit late, so I will not spend time on the introductions. These experts are internationally recognized lecturers and scientists. Dr. Gerhard Iglaut, former president of the German Society of Implantology, acclaimed international lecturer in implant dentistry and soft tissue surgery. Professor Ronald Young is a professor in implant dentistry, University of Zurich. Again, one of the top stars of the European scene in implant dentistry. And finally, Professor Mark Urainen, who is not that young like the one that is speaking with you, but still is one of the highest recognized researchers and teachers, professor of periodontology, head of the department at the University of Leuven in Belgium. So welcome you all and welcome to this symposium. We have heard the presentations, and I would like to start the interaction. And of course, this is a debate, so if you feel that you want to interrupt the person that is speaking or you want to add something, go ahead and do it. In the meantime, I will try to address questions specifically to you all. Let me start with Gerard. Gerard, you know, well, I know, and most of the people know, that probably you are the most experienced clinicians or among the most experienced clinicians using these biomaterials. You have lectured extensively and you have used it in many different applications. So my question is, we've seen this morning the application of these soft tissue substitutes in the treatment of localized or generalized gingival recessions around teeth and a little bit around implants. So I'm going to ask you a little bit more in implant dentistry because we suffer a lot of soft tissue problems in our implant patients. Do you think these biomaterials would eventually substitute the need of autologous harvesting in our patients? What is your clinical experience?
As you already said, I'm working now for 6 years with this new material, and I have about 20 years used the human material. As you already mentioned, Pat Allen, he inaugurated in the beginning of 2000. So when we moved to the porcine material, what was very surprising for Pat and mine, that it worked more predictable than the allergen material. So this was in the first moment very surprising. And as we already heard, the material shows excellent outcomes, really impressive healing. This is what was from the first moment very, very surprising for us. So we started, of course, with using it for root coverage, but after a time of experience of 2 years, we start using it around implants. And what I can say now is we can use it really predictable. We can use it in double layers, as already Andres mentioned. And the outcomes we have already from the timeline is about 3 years. So we see stable outcomes around implants too. So it might be a good option in future. And we look forward to more scientific base. And what is for me great pleasure that we will start a clinical trial in the next weeks together with Tony Sculian, and then we can show you, let's say, in 6 months, first results. This is root coverage around teeth, and the next step, of course, will be around implants. But the experience are very positive right now, and we look forward to future outcomes on future science on this.
Thank you, Gerard. And of course, we look forward to these results. Let me move to Professor Young, Ronnie. You have vast experience in using these biomaterials for volume enhancement and improving the aesthetic results of implant-supported restorations. One of the critical issues that you have published extensively is the need of volume enhancement. what would you ask these biomaterials in order to achieve this volume enhancement around dental implants?
Thank you very much, Mariano. And I actually just wanted to, I couldn't almost hold myself back to ask Gerhard, because I would like to better understand. It always sounds so positive, but I would like to understand which are then really the indication, and then I maybe talk for the collagen part, but then when it comes to the acellular matrix, where you don't use these materials, where you say, here, I do need to have an autogenous material. That's would like, as a clinician, I would like to better understand when I cannot use that. And then maybe I can answer the question, how I see it, when I come back to Mariano's question regarding the use then of the collagen matrices in terms of volume, and when I do see the limitations there.
Okay, Gerard, do you want to answer to Ronnie?
Sure. In my office, I suggest my patients these materials, of course, for primary root coverage and for deficiencies around implants, but the main aspect is the patient. He decides whether he wants to get harvested on the palate, and a lot of patients in my office refuse to use connective tissue grafts. From my opinion, it's very important to understand if patient has no problem using this connective tissue graft from the palate, and we have a recession or let's say want to thicken the tissue, soft tissue around implants, it's no doubt about you can use the connective tissue graft. But when we see to the more severe cases where we have limited availability, then the absolutely number one is this porcine cellular dermal matrix, actually.
So you elegantly passed by actually my question, because I think at the end it's not the patient which can only decide. You as a clinician actually need to kind of evaluate the clinical situation and then judge, here both treatments are equivalent, or here in this specific situation with this material we might not achieve the same result. But when I hit the ear, there is no difference anymore. You can use for everything the acellular dermal matrix.
At the moment, I have no idea. At the moment, I have no idea how to cover, let's say, sockets. So we have to exposure it to the oral cavity. So in such cases, I would prefer the combined graft still from the palate, because we have no experience what happens over time. And of course, we could get infection if we keep it not uncovered. So this is, for me, a clear, let's say, use of connective tissue graft and of course, this combination with a free gingival graft.
Let me ask Professor Kuirainen, because Mark has extensive experience of using biologicals, what Professor Blanco alluded as the biological push. In your opinion, do you think biologicals have an important added value when using these soft tissue substitutes?
Thank you, Mariano, for the question. First of all, I think opinions are of no value. It should be the evidence that answers questions. And I did a little bit of homework last night, and you can find in the literature, for example, 9 papers that are checking or comparing the effect of a connective tissue graft with, for example, LPRF. And if you examine those papers in detail, you will see that, I have it here on my table, 6 of these 9 papers published that the results, the outcome for root coverage were the same. So these biological components like LPRF, which is, by the way, 100% autogenous, which does not apply a donor site, they really seem to work quite well. And I think it has been said already during the presentations that the patient is, of course, the most important parameter in this treatment. And if we can do a treatment without giving any pain to the patient, I think we have to go for this. So I think that LPRF can also be a good alternative towards a connective tissue graft.
Can I ask Ronnie, back to you? One of the things that we look when we are using these biomaterials is, of course, the chemical properties, of course, the biocompatibility, biodegradability, but also the physical properties, the porous size of the matrix, the resistance to pressure, the manageability when we are working with them in surgery, specifically for that part of the research you've been working personally, which is volume enhancement around dental implants. What is what you really ask for these soft tissue substitutes when you are using them for this particular indication?
Thank you, Mariano. So a material which I would like to use is a material which provides me for very in a predictable way a volume increase. When it comes to bone regeneration, there we want to have a specific tissue. When it comes to soft tissue volume and the aesthetic area, we might not that much ask for what kind of tissue it is. We just ask for having sufficient volume in this area. These volumes should be maintained over a long time period. And when we talk about long-term period, that needs to be 5-10 years data, which we need to have available for these type of materials. And there I see the limitations of the materials, which we have seen also this morning, where I don't, also when I see the compromise result by Andres, when he did the augmentation of this kind of trying to switch the biotype, I'm not convinced that we are able to switch biotypes with these substitute materials. When it comes to volume stability with collagen matrices, I think you referred to that we did a lot of work with a three-dimensional, more volume stable collagen matrix, where we do have data available now over 3 to 5 years, which we are all able to be comparable with what we have achieved with the autogenous grafts. But again, for me, it was important, especially when it comes to implant 30, when I can use these materials for volume stability or for volume increase only when I have ideal conditions. When I have compromised situation, I do not believe, and that's what I also have seen now in the clinical situations, that they were really able to there and with Mark, that we need to have the add of kind of autogenous support, whether it's LPRF or whether it's just a graft, it's up to debate.
Thank you, Ronnie. And of course, this is a question that I make for the three of you. Of course, we live in a world of synthetic biomaterials. As you know, the European Union will not support any human-derived or even xenogenic-derived biomaterial for future research because they believe the future is synthetic. Do you believe combining synthetic polymers or synthetic substances with biologicals, we can also achieve some of the results we are getting in bone regeneration with soft tissue regeneration? Let me start with Professor Kurinen.
Really difficult question. To be honest, Mariano, I have no clue. I am a little bit afraid if we go this way. I think we have to trust what we have today. We can achieve fantastic results. So why change a winning team?
Okay, but we are discussing whether with human-derived material we have more or less inflammation. We are discussing whether with use of xenogenic material we may have some very unlikely but possible viral or microbial transmission. So probably in the future we should also try to take these things into consideration. What is your outlook, Ronnie?
Yes, thank you very much. I think I'm getting really excited when we talk about these topics, because personally I do think we still scientifically waste too much time in order to try to mimic human materials by having xenogenic or allergenic materials. Because I'm totally convinced, and I think this is also the right direction to go to, that we need to work much harder on synthetic solutions, which act as not as a. We should not talk about anymore as materials. We should talk about structures, which provides then three-dimensional scaffolds combined with biomediators to really go in a direction where we would like to go to. So I think that's, for me, absolutely clear. This must be direction. And I'm somewhat surprised how little is actually done in research in these directions. And knowing, personally involved in development like this, taking up to 15 years just to get the first clinical results. And I think our companies, which we, in our dental environment, they're not often not in such a long-term way. They want to have earlier results. But to make it clear, I do think we waste a lot of time in looking into allogenetic or xenogenic materials.
Finally, Gerhard, what is your outlook to the future in terms of biomaterials for soft tissue enhancement?
I can 100% agree to Ronnie's opinion. I hope for the future that we get these opportunities, and we have to work very intensive in the future and not to lose any time on other things. We have now a good basis, but the future have to go in this direction.
Thank you. And well, we have basically 4 minutes to finish the symposium, and I would like to have each of you the opportunity to say some final remarks. So we have heard great presentations, clinical applications, basic biology about a future or a current, I would say, a current approach to the treatment of soft tissue deficiencies around dental implants and around teeth. How would you like to conclude, Mark?
Well, first of all, I think it was a great morning. I'm sure that we have to be very careful in preparing patients before we place implants. An increase in gingival width is one of, or peri-implant mucosa width keratinized is one of the key issues. And then in perio, I am convinced that today we have already a nice arsenal of treatment possibilities. And the new product seems to be also very promising. So I'm really looking forward to RCTs showing the benefit of this new technique or this new material.
Thank you, Mark. And I pass the word to Gerhard. Make some summary conclusions, please.
Yes. For my opinion, it's very important for the future to work on techniques and materials which works in many hands. That's why we have to think about how we can lower technique sensitivity and what materials helps us to get predictable outcomes. But important is how we can use it and how we can put it in our, or use it in our hands. We need a smooth surface. We need very uniformly sizes and thicknesses, which helps a lot in our techniques. So this is, for my opinion, so important to work on perfect techniques, which works in a lot of hands. And Of course, I'm not convinced that we can use it properly in cases like we saw around implants. If the implant is in a wrong position, I'm convinced we have to take it out and to overwork the case again.
Thank you, Gerard. And Ronnie, what is your outlook of what we have heard and what you would like to say?
Okay, let me do it in two ways. Number one, I put my hat on as a researcher, and from that point of view, I really think what Tony Scullion showed regarding the uptake and release of the mediators out of the collagen matrix, that's a basic understanding which should go further in order to be able then to go more into synthetic solutions to better understand these mediators. And having the clinical hat on, I would like just to summarize for the audience, and I do hope that the colleagues agree on that. Every artificial substitute material we have is ideal when we have good soft tissue conditions, deficient, but good soft tissue conditions to cover, where we have sufficient keratinized tissue and also quality to cover. But whenever we have really to deal with compromise situation, with failing cases, soft tissue defects in there, where we need to increase volume and quality, then I do still think we need to have autogenous materials and mediators involved in these situations.
Thank you, Ronnie. And let me a little bit also give you my impression. I think that we utilize these biomaterials as well as the autogenous grafting because two situations, either because there is a tissue lost as a consequence of tooth extraction, for example, when we are placing implants, or because we have lost the tissue due to trauma or infections. We know very well around teeth that normally we will have these localized gingival recessions as a consequence of trauma, but on a very specific situation where we have tooth malpositions or where we have extremely thin phenotypes. And these situations, which are anatomical, structural situations, they can be very challenging, as we have seen from some of the beautiful cases presented by the lecturers. And sometimes, as Dr. Pascual was stating, we are demanding too much of biomaterials that are there to support our surgical techniques, are there to improve a little bit our predictability to achieve good clinical outcomes. But the biomaterials, as we have heard, do not substitute at all the precision of the surgical technique and the importance of the design and the application of the different flap approaches. Of course, there is not one better than the other. We have heard from Professor Scullion that he rather use tunneling approaches not to raise the papillas, but clearly we have seen and we have ample literature from other approaches where reposition flaps coronally or laterally can attain very similar outcomes. So in that sense, I think these biomaterials can give us an opportunity, as Dr. Gerard Iglau was mentioning, to use them whenever our patient is not very willing to donate their own palate for the purpose. And I think it's important to have the accessibility of these biomaterials. Clearly, we need a lot of clinical research to understand whether this biomaterial has advantages over the other. And also, it's very important to have good clinical research to understand which are the specific indications that these biomaterials may be used. We have heard from the presenters and also the panelists in this discussion that probably peri-implant soft tissue deficiencies and volumes enhancement indications are more challenging, and probably we sometimes are demanding too much from these sort of inert matrices, either xenogenic or human-derived. Also, we have heard whether some lecturers have mentioned the importance of full submerged approach on the use of these biomaterials, not to allow them to heal in a non-submerged environment. But however, we understand that there are specific indications, mostly around dental implants, when we have to enhance the band of keratinized tissue, that a non-submerged environment is absolutely the way to apply these biomaterials. So there is a lot still that we need to understand. There's a lot still that we need to learn. And we, I think, are in a better situation today after listening to this symposium to be more enthusiastic about doing the research, about doing the clinical studies, and about, of course, applying what we have learned in our patients. So I'm going to close by, we have only 3 more minutes to go before closing, and I would like to ask our 3 panelists the last minute to say the final words. So please, Gerhard, your last minute.
Yes, I think it was a very nice meeting today, online meeting, and it was for me very interesting to see the cases from the colleagues and of course from the scientific base we got from Tony and the really great work done by Andres. So this makes me very positive thinking in the future of all these techniques, and we will go on in the atraumatical direction. Of course, tunnel procedures is clear future, but there are still cases where we have to make incisions when it makes sense related to the specific cases and sites. But I'm convinced we have now new options with these materials we didn't have before. Thank you so much, Mariano.
Thank you, Gerhard. And please, Mark, your last minute.
Well, I would like, it's difficult to add already something to the previous expert, but I was amazed by the basic science that I have seen today. And I'm going to take some of these this info, bring it into my mind, and it will help me for future research, of course. And as I said already some minutes ago, I think this new product seems to be also very promising and especially good for the patient.
Thank you, Mark. And please, Dr. Yang, your last minute.
Thank you. So after this morning, I'm really very excited to see how many options do we have now available, because there's not that long ago, years ago, which we did not have that many opportunities. And I think for that point of view, it really adds a lot to our tools using in daily practice, but also adds a lot to see, as you said, Mariano, how much we need to advance also in questions and research questions to even better understand the principle of these materials. But they definitely have led to the direction of, as Gerhard always says, to reduce the invasiveness, to reduce the technique sensitivity, and to increase the predictability of our treatment, of our patients' treatment.
Thank you very much. And I would like to end up by thanking Spanish Society of Periodontology and the Oral Reconstruction Foundation for putting together this symposium. And of course, to thank all of you that have been patiently listening to this in your homes. And hopefully soon we will be able to go together with our colleague Juan Blanco to Santiago de Compostela, where we can not only enjoy Santiago de Compostela, but also enjoy our presence and enjoy the company of so many friends and colleagues that we missed so much today under these circumstances that we must endure, and of course we must follow what the recommendations tell us to do. Thank you very much, and hopefully see you soon. Thank you.
NovaMatrix is the next generation soft tissue augmentation material intended for root coverage, gingival augmentation, and alveolar ridge reconstruction applications. The NovaMatrix reconstructive tissue matrix is surgically attached to the desired anatomical location to create a proper interface and regenerate soft tissue. The three-dimensional architecture of NovaMatrix allows blood vessels to grow into the surgical site. NovaMatrix provides a conduit for host cells to penetrate, adhere, proliferate, and populate the reconstructive tissue matrix. The cells contribute to the remodeling by creating a new host tissue. NovaMatrix provides the proper environment that balances mechanical properties of the reconstructive tissue matrix with the host cellular mechanisms of wound healing. This leads to the remodeling of tissue and ultimately the regeneration of soft tissue. The transition of NovaMatrix reconstructive tissue matrix into host tissue restores the physiological and anatomical properties of the surgical site.